हेलो फ्यूचर डॉक्टर्स, वेलकम टू टुडेज मास्टर क्लास। आज हम एक बहुत ही हाई यील्ड टॉपिक डीकोड करने वाले हैं, लिवर डिसऑर्डर्स इन प्रेगनेंसी। देखो, whether you're an MBBS student surviving the wards or a NEET PG aspirant grinding through revisions, you know that pregnancy is a massive physiological stress test. And when the maternal liver takes a hit, it can literally be life-threatening for both the mother and the fetus. So, ध्यान से सुनना, focus यहाँ रखो, because today we're going to break down the big 3 liver disorders you absolutely must know for your exams using crystal clear concepts. So, फटाफट roadmap देख लेते हैं. Number 1, the big 3 overview. Then, HELLP Syndrome. Third, AFLP or acute fatty liver. Fourth, differentiating AFLP versus HELLP. Fifth, ICP, which is intrahepatic cholestasis. And finally, a high-yield revision. This exact structure is going to help you mentally map these conditions perfectly for exam day. चलो, शुरू करते हैं. Section 1, the big 3 overview. Like I said, pregnancy puts immense metabolic and hemodynamic stress on the maternal liver. जब complications आती हैं ना, especially in the 3rd trimester, we have to be able to categorize them perfectly. These big 3 are the ultimate culprits you'll see time and time again. Section 2, HELLP Syndrome Demystified. Let's kick things off with the absolute most classic complication of severe preeclampsia. Now, what's really amazing here is that the name itself literally gives away the entire pathogenesis. H stands for hemolysis, specifically microangiopathic hemolysis. EL is for elevated liver enzymes, and LP, low platelet count. एक बात हमेशा याद रखना, you need all 3 of these to be present for a definitive diagnosis of HELLP syndrome. It is typically a severe complication of preeclampsia, meaning you're going to see raised BP in about 80 to 85% of these patients, and it's definitely way more common in multigravida females. So how does the patient actually present in the ER? Mostly in the 3rd trimester, or sometimes within 48 hours post-delivery. Now catch this, the most common symptom initially isn't jaundice. Actually, it's right upper quadrant abdominal pain. Concept समझो यहाँ पर. The liver capsule is stretching. To diagnose this, we use the Tennessee criteria. For hemolysis, you need any 2 markers, burst cells or schistocytes on a peripheral smear, serum bilirubin 1.2 milligrams per deciliter or higher, LDH massively elevated over 600, or decreased haptoglobin. For elevated liver enzymes, SGOT and SGPT must be at least 2 times the normal value. Now here is a golden exam pro for you. ALP, or alkaline phosphatase, is not considered for diagnosis. Why? Because ALP normally be pregnancy may elevated HEHOTI due to the placenta. And finally, for low platelets, the count drops below 1 lab. Management of HELLP is a classic 2-step strategy. Initial management is all about maternal stabilization. You give MGSO4 to prevent seizures, because remember, this is deeply tied to severe preeclampsia, and antihypertensive drugs to control that blood pressure. Right after that, you administer the first dose of corticosteroids and go for immediate induction of labor. Kyun? Because the definitive management is the termination of pregnancy, irrespective of the gestational age. Delivering the baby is the ultimate cure here. Section 3. AFLP. Acute fatty liver of pregnancy. You absolutely cannot afford to miss this condition on the wards. AFLP is actually the most common cause of liver failure in pregnant females, and it carries a terrifyingly high mortality rate of around 10%. It usually presents in the 3rd trimester, strictly between 30 to 36 weeks. The clinical presentation might trick you at first. The most common initial symptoms are simply nausea and vomiting, which can then rapidly progress to fulminant liver failure, jaundice, ascites, and hepatic encephalopathy. Risk factors? Retta Marlow, a previous history of AFLP, twin pregnancy, preeclampsia, and carrying a male fetus. The mnemonic is super simple. Male twins previously affected. Male fetus, twins, preeclampsia, previous history. Easy, right? And hey, while HELLP uses Tennessee criteria, AFLP is diagnosed using the Swansea criteria. Now, this brilliantly illustrates exactly why AFLP happens. Let's break down the pathophysiology step by step. It is all about an enzyme called LCHAD, long-chain 3-hydroxy-acyl-CoA dehydrogenase. Step 1. The fetus has a homozygous deficiency of this enzyme, causing a total defect in long-chain fatty acid oxidation. Step 2. Because the fetus can't break them down, intermediate products of fatty acid metabolism accumulate in the fetal circulation and cross the placenta right into the mother's circulation. Step 3. The mother happens to be heterozygous for this LCHAD deficiency. Normally, she's perfectly fine, but now, she is facing a massive load of fetal fatty acid intermediates, and her capacity to oxidize them is severely limited. Step 4.
The end result is a massive accumulation of fatty acids in the maternal liver, causing severe free radical damage. And this fatty acid accumulation and free radical damage, it doesn't just stay in the liver. Yes, for sure you get severe liver failure with deranged enzymes, profound hypoglycemia, increased ammonia levels, and a very high risk of DIC. But look at the systemic hit. The free radicals trigger acute pancreatitis, widespread endothelial cell injury, and associated renal failure marked by increased serum urea and creatinine. Basically, it is a massive multi-organ disaster. Section 4, AFLP versus HELLP Syndrome. This right here is the make-or-break section for your exams. How exactly do you differentiate AFLP from HELLP when a third trimester patient crashes in front of you? I want you to take a mental screenshot of this right now. Examiners love to give you a long clinical vignette, and you have to spot the tiny differences. First up, criteria. AFLP uses Swansea, HELLP uses Tennessee or Mississippi. Next, and this is literally the most important differentiator, hypoglycemia. If the patient's blood sugar drops below 72 milligrams per deciliter, boom, think AFLP. Hypoglycemia is classically absent in HELLP. Similarly, high ammonia levels leading to mental confusion, that's a hallmark of AFLP, but it's normal or completely absent in HELLP. What about DIC? It's a much higher risk in AFLP, meaning you're going to see prolonged PT, APDT, and low fibrinogen. Finally, associated systemic issues like pancreatitis, transient diabetes insipidus, and early profound renal failure strongly point towards AFLP. Clear, hey? Let's keep moving. Section 5, ICP, intrahepatic cholestasis of pregnancy. This one is unique because it's completely tied to pregnancy hormones and is fully reversible, though it does tend to reoccur in future pregnancies. So what's the core issue here? In ICP, bile acids are incompletely cleared by the liver, and they just accumulate in the plasma. This usually happens in genetically susceptible females when they get exposed to those massive third trimester spikes in estrogen and progesterone. And what is the absolute classic first symptom? Pruritus. Intense, uncontrollable itching, but not just anywhere. It has a very strong predilection for the palms and soles, and it is almost always worst at night. That is a massive exam pearl. Then, usually about 4 weeks after the itching starts, the patient will actually develop jaundice. Now, while the mother is extremely uncomfortable, the real true danger of ICP is actually to the fetus. Let's trace the pathophysiology of these fetal complications. The maternal bile acids cross the placenta and reach the amniotic fluid. The fetus naturally swallows this amniotic fluid laden with toxic bile salts. From here, 2 very dangerous pathways open up. Path A, the bile salts irritate the fetal bowel, causing the fetus to pass meconium prematurely into the amniotic fluid, which leads directly to meconium aspiration syndrome. Path B, even more devastatingly, the bile salts can accumulate in the fetal heart, disrupting electrical signals and leading directly to cardiac arrest and sudden stillbirth. This right here is exactly why we monitor these pregnancies with such extreme caution. So the crucial point is rapid diagnosis. If you suspect ICP because a pregnant female complains of severe nighttime itching on her palms and soles, what is the absolute best investigation? You must order serum bile acid levels. A level greater than 10 micromoles per liter is diagnostic. Rutlo ISCO, do not forget that number, greater than 10. Okay, let's look at how we actually manage this. For the mother, the drug of choice is ursodeoxycholic acid, or UDCA, to help clear out those bile acids. But you must also give an injection of vitamin K. Kyon? Because the accumulated bile acids in the gut prevent the absorption of fat-soluble vitamins, leading to a huge drop in vitamin K and a massively increased risk of postpartum hemorrhage. We start intense intrapartum fetal monitoring at 32 weeks with weekly NSTs and biophysical profiles. But ultimately, because of that terrifying risk of sudden stillbirth, we terminate the pregnancy via induction of labor at 36 to 37 weeks. Never let them go to full term. After birth, ensure the newborn also gets a vitamin K injection. And a quick clinical note for the wards. OCPs are strictly contraindicated in these patients postpartum, and they have an increased lifetime risk of developing gallstones. Section 6, high-yield rapid revision. Okay, we have covered a ton of complex pathophysiology today. Let's do a rapid revision to lock in the absolute highest yield takeaway from this explainer. Think about it for a second. We have HELLP, which is driven by preeclampsia and microangiopathic hemolysis. We have AFLP, driven by a genetic LC8-ChAd enzyme deficiency causing fatty acid buildup. And we have ICP, driven by hormones and bile acid accumulation. Despite all these completely different mechanisms, what is the ultimate definitive management for all 3 of these when they become severe? The answer is prompt delivery or termination of pregnancy. Getting the baby and the placenta out removes the driving stressor, whether it's LC8 intermediates, extreme hormones, or preeclampsia. Once delivered, the mother's liver function usually bounces back to normal within a week. Keep that unified concept anchored in your mind, and you will not get tricked on exam day. But ask yourself this: what happens if you deliver the baby and the maternal liver enzymes actually continue to rise? What hidden postpartum pathologies should you hunt for next? Think about it. Thanks for tuning into this masterclass. Keep revising, and I'll catch you in the next one.